friends, today we are going to discuss here about very high yield questions for medicine. Question number 6. A 50-year-old man with Crohn's disease of ileum and had intestinal obstruction. He underwent resection and anastomosis of ileum 10 days later. He arrived in ER with a 1 liter bilious leak from the drains. He is managed with antibiotics, total parenteral nutrition and nil per oral regimen. 4 days later, his ABG is pH is 7.24, that is acidic, and partial pressure of oxygen is 98, PCO2 is 40, and an ion gap of 10. What is the most likely cause of this ABG? Renal failure, diabetic ketoacidosis, hypovolemia, small bowel fistula. So guys, now this question is visible in front of you. Try to answer in comment section. If you want, you can pause this video at least 60 seconds or 1 minute in your hand. Try to answer. So here, best answer here is small bowel fistula. Why? Let's discuss. This patient has high output fistula with normal anion gap. The patient has metabolic acidosis with normal anion gap, which happens with loss of bicarbonate, pancreatic fistula, diarrhea, small bowel fistula, or gain of chlorides, excessive saline infusion. Let's begin. Next MCQ. Which of the following is not associated with peptic ulcer disease? Zollinger-Ellison syndrome, primary hyperparathyroidism, cirrhosis, pernicious anemia. So, which one is not associated with peptic ulcer disease? So, try to answer in comment section. If you want, pause this video for 1 minute. Try to answer in comment section. So, best answer here is pernicious anemia. Why pernicious anemia? Pernicious anemia has a chlorhydria in which the chance of ulcer formation are rare. That's why pernicious anemia. Peptic ulcer is associated with host condition. It includes infections, H. pylori, HSV, herpes simplex virus, CMV, cytomegalovirus, Helicobacter, Pneumoniae, or other rare infection like TB, syphilis, mucormycosis, etc. Hormonal mediator induced including acid hypersecretory states like Zollinger-Ellison syndrome, that is gastrinoma, systemic mastocytosis, basophilia in myeloproliferative disease, antral G cell hyperfunction, existence independent of H. pylori is detectable. Okay, some other causes like drug exposure, NSAIDs and aspirin, including low dose aspirin, bisphosphonate probably when combined with NSAIDs, clopidogrel when combined with NSAIDs or in high risk subject, corticosteroids when combined with NSAID, sirolimus, spironolactone, probably no data with NSAID, co-therapy, mycophenolate, mofetil, potassium chloride, chemotherapy, example hepatic infusion with 5-fluorouracil. These are the causes. Some post-surgical causes like antral exclusion, post-gastric bypass, vascular insufficiency including crack cocaine use, mechanical duodenal obstruction, annular pancreas, radiation therapy, infiltrating disease, sarcoidosis, Crohn's disease. So these are the causes. Comorbid ulcer associated with decompensated chronic disease. All options in front of you. I'm not going to details too much. Which of the following is associated with metabolic alkalosis? Gain in fixed acid, loss of base, rise in base excess, or hyperkalemia? So guys, try to answer in comment section. Associated with metabolic alkalosis, that is loss of base. Let's discuss little bit about this. Increase in base excess is associated with metabolic alkalosis. Metabolic alkalosis is associated with loss of fixed acid and hypokalemia. Classic example is vomiting and pyloric stenosis we find. Now, true about reactionary hemorrhage after cholecystectomy. It is commonly occurs within 24 hours after surgery. It is caused due to infection, mostly because of slugging of tissue. It is more common than primary. What is single best answer here? If you want, you can pause this video. If you know the answer, you can answer when you are sleeping. So answer is, it is commonly occurs within 24 hours after surgery. Reactionary hemorrhage is less common than primary hemorrhage and is most commonly due to dislodgement of clot and over-aggressive resuscitation. It is not due to infection, it can be due to spillage of knots and suture. Most of the time, re-exploration has to be carried out. Secondary hemorrhage is due to infection, pressure, necrosis and malignancy. Now, which of the following patient of appendicitis do not have increased risk of perforation? So, which patient do not have increased risk of perforation? Children, patient on tacrolimus, obese, pelvic position of appendix. So, which one? Try to answer in comment section. So, guys, if you want to join INI-CET high yield topic wise important videos, 600 high yield topic video for INI-CET, fee 7,000 rupees only. For Neet PG 2024 exam, also paid subscription program available, fee 7,000 rupees. Total topics are 800. Same day of joining I provide you 500 topics. So how to join that subscription program? Details available in description of this video, and helpline WhatsApp number is also there. So answer here is obese. Okay. Some group of patients have increased risk of perforation of appendix. These groups like extremes of age, patients on immunosuppression, pelvic appendicitis, fecal obstruction and diabetes mellitus. So guys, thank you. If you like this video, put like on it. Somebody is new on my channel, please subscribe it. And if you want more such videos, you can write in comment section. Thank you.